And if we take glucose translucency, just an example of imaging, like the central nervous system, right? Here, this is an example in Hong Kong. We do the first trimester of down swimming plus the anti, and if it's a high risk, we will do phenotyping and microarray nowadays. I mean, that was the practice in a public hospital. But again, if they are normal, is it normal? Okay, what's the level of technology can help us to understand that? Okay, so I've shared with you yesterday. What I want to focus today is that we know we do phenotyping because we are able to look at the copy of the encyclopedias. We know that we now have the chromosomal microarray because we can look at the chapter, and even you can see that a lot of the section of chapter by using this microarray technology. And we also understand from the previous speaker that we have point mutations. So in this regard, I'm asking about we have 3 different diagnostic tests. What should be reprioritized, and when we should consider which one to go first in order for the testing? Because in prenatal, we only have a very short period of time to intervene, and also actually, it also depends on whether you got the amniocentesis series or photosynthesis sample. The volume and amount of DNA you are able to do the test is also very minimal. Okay, so first of all, advanced technology. NIPT is advanced technology, non-invasive prenatal testing. But we understand that nowadays it's not just for common trisomy 31, 18, and 21. So if we take central nervous system as one of the examples of ultrasound abnormality, should we consider use of NIPT in our testing? Okay. And if you look at the guideline, this is one of the guidelines for the International Society of Prenatal Diagnosis. NIPT is recommended for aneuploidy screening in all pregnancy, regardless of maternal age or other risk. So if we take this as a statement, then yes, NIPT should be one of the tests we're going to consider. But do you know the test scope of the NIPT you are ordering? How many of you have really looked into your report and understand is that the NIPT you order in Vietnam, same as the one we order from Hong Kong, from UK, or from France? I'm sure the basic is common trisomies, right? 13, 18, 21, and then you may have the sex chromosome disorder. But how about microdeletion panel? How good are they? Do you know what's the positive predictive value? And also, if we're talking about advancing technology, in Hong Kong, we go down to 3 million base pair for the whole genome, for the NIPT. But that's only in Hong Kong. Other places, they only go down to 6 million base pair. Okay, so that's already telling you the real difference and the level of understanding we have. So, okay, so if we set this as a stage, we go back to angiogenesis of corpus callosum that I have introduced yesterday. We know that there are about 17% of the cases they have common trisomy. Okay, so we worry about trisomy 18, trisomy 13, yes, but I also mentioned there's a mosaic trisomy 8. Okay, so if you do NIPT, right, you have to be aware what is the scope of the test that you are interested in, and that is the relevance. Okay. And then I also mentioned that there are more than 200 monogenic disease or conditions that we follow. I mean, even this morning, Professor Mark Cuby was able to attend such regarding the gene list and the conditions. So when we do NIPT, actually we are only look at the tip of the iceberg. Okay? And also, we know this is only a screening test. Right? We have to understand that when we measure the cell-free DNA in the maternal plasma, actually it's a mixture of cell-free DNA from both the maternal and the placental origins. Okay, so we are taking some of the signals from the hematopoietic cells or the organ from the mother, and we also look at the placenta trophoblast. Okay? And we have to pay attention for the fetal DNA pattern as well, because that is the true signal when you're doing the NIPT measurement. So with that, we need to understand that, Why sometimes the NIPT does not work? Because there are biological factors influencing the fetal fraction. Right? If the fetal fraction is too low, you do not have a good measurement. So gestational age, usually we practice after week 10 for NIPT. Maternal weight, BMI is an issue. If the woman is very chubby, actually your relative proportion of cell-free DNA is less as well. Placental size, of course, whether it's a monozygotic and dizygotic twins is also important, right? Fetal genetic conditions all are very important factors you need to consider. But as I mentioned, it's only a screening. Okay, so for diagnostic tests, of course, it depends on your gestation week. I know that CVS is less popular here. We do more in Hong Kong, and at least we all do amniocentesis. So the question here is that when you have the first test, how many of you ever think of, do they exclude maternal cell contamination? How severe is maternal cell contamination in your daily practice? I think this is a very old paper, but I want to show that even in the old days in the US, not all the labs, they will check for maternal contamination first before they run the test. So what's the risk? Very simple. When you do amniocentesis, it looks nice, right? But after you spin it down, it's not uncommon. You can have a mistake. So when you take the DNA, if you are not sure whether there is maternal contamination, what you are measuring the maternal sample. It's the same for CVS. This is a typical CVS we got from most of the clinicians. Very scattered, right? Do you know which one is the CVS, which one is the maternal decision, right? Not many of you can understand. Actually, we need training in the lab as well. That's more related with the relevance in the laboratory. But what I want to bring up is that, what's the best test? Simplest one, right? I echo what Professor Mark gave me this morning said. Actually, quantitative fluorescent PCR. It's an old technology based, very fast. I understand even from the hospital locally, only a day you have a report. So it's very important. It's a very simple principle because in our genome, we have a short tandem repeat, we call STR, that between you and me, actually our repeat number is different. So by differentiating this repeat number, we know that whether we inherited the copy from our parents, they're the same or not. But also at the same time, if there is another genetic material from a third person, a contamination from a lab, a contamination from the maternal, we're able to very easily by seeing these repeats, right? It looks complicated, but very simple. What I want to show is that the left one is for XY chromosome. So if it's a male fetus, it's 1-to-1. So as simple as that. This is how it works. Right? So you look at all the markers and understand whether there's a maternal contamination or not. So like this one, you can see that the repeat ratio is not equivalent. So we know that there's a possibility of maternal contamination. Of course, the next level, it could be a mosaic turner as well in a male fetus. But I mean, that's the next level. What I want to show you is that qPCR is really a good method, right? It's a reliable method to detect common trisomy, and it can be based karyotyping to detect trisomy 13, 18, 21, and Turner. And that is already a recommendation for more than 20 years. Right? So when you do have a case with central nervous system abnormality, you suspect common trisomy. One of the first best tests with a turnaround time of 1 day, actually you can do qPCR. And it also excludes the possibility of sample contaminations and maternal contaminations. Okay, so actually that also changed the algorithm in Hong Kong. This is the algorithm. I apologize for the small print. We have been implemented in our Hong Kong public healthcare system. You can see that from now on, any patients, because of primary indications for invasive procedure, we will first do a qPCR on the left-hand side. Okay, and then if the qPCR is negative, we don't go for karyotyping anymore. We go direct for the chromosomal microarray. The reason for that is because by the chromosomal microarray, no matter from the New England Journal of Medicine earlier study or from in-house or data from Europe or of our other audience, we can see that chromosomal microarray increase the diagnostic yield. And also the turnaround time is faster. Most of the lab, your microarray turn back with results within a week. For your karyotyping, it takes 2 weeks to 3 weeks. So both the turnaround time as well as the diagnostic yield has been enhanced by CMA. So that's why in 2019, in Hong Kong, we start to implement these new algorithms. Okay, so with this algorithm, the main argument why we want to do chromosomal microarray is first, compared to calteching, we have a better resolution, about 50 times more. Second, if you look at the graph on the right, that is a multi-cohort study of over 9,500 pregnancies. You can see that the prevalence of microdeletions stayed static compared to what we know for common trisomy. We know that for advanced maternal age, your risk for common trisomy is high, but your risk for microdeletion, if you consider for a young age group, actually is higher than trisomy 21. And you are not able to be detected by calteching. Only microarray are able to detect for that, right? And also our subsequent study further enhanced and proved that pathogenic papilloma variant, we talk about anything smaller than 10 million base pair, that means they are unlikely to be detected by calteching, is actually have a high, presence. Even for those with a relatively low risk, you have about, a risk like the New England Journal of Medicine is about 1.6%. So this argues why we need to do chromosomal microarray rather than calteching after invasive procedure. And there's so many guidelines, right? They all say that CMA is a well-established and proven test to identify pathogenic papilloma variant in fetus with ultrasound abnormalities. Okay, and actually they have been recommended to be applied for any specimen that have done an invasive procedure that they should consider and inform the patient that CMA should be an appropriate testing to be considered. Okay, so is that all? I've already explained to you what we are doing, but still we can have cases with imaging, right? Fetal brain MRI or others, they're still abnormal. So what is the next consideration? The next consideration actually is we consider what is unable to be resolved by chromosomal microarray, which is most of the time is monogenic disease. They are very rare, but we add all the rare genetic disease together. If you look at all the undiagnosed disease network, it could be as high as 1 in 10. Okay, so if it's 1 in 10, it's much higher than what I have just presented to you on all the tests that I just showed you. But why we need other? It's because when we look at the chromosomal microarray, okay, you can see that all those bars I showed you, actually, they mean the plots of all the different platforms. You can see that for one of the typical genes where the blue is the exons, this is the intron, you know that the distribution and the density of the microarray is not very even. And even some of the platforms, they may not have the probes on it. That's why they were not able to detect. Okay? And also for microarray, our report is that we only detect anything pathogenic larger than 100 kilobase pair. Right? Remember my first slide? We have gene that's point mutation. Point mutation were out of the scope of this method. That's why after CMA, we still need to consider what's the next. That's why we have genome sequencing and exon sequencing. So for exon sequencing, it's more simple. We only take care those of the region they are coded. Okay, so the red one, so that they contribute about 1.5 to 2% of the genome. So it's much easier. Just like an apple, when we do exon, we are only taking a slice of the apple. We are not talking about genome today because it's too much information. We are talking about what have been clinically and practically implemented in our prenatal diagnosis. So exon sequencing, what they do is that you need to do capture. So you need to take all the exon regions and then do a sequencing. Okay, so in that regard, remember this capture. Just like you want to catch the fish from the beautiful lakes around here. How deep is your capture? That's very important, right? There's a lot of commercial company and there's a lot of lab that's accredited. It's mainly what we talk about is what is the coverage of the exon. Are we doing a 100 times coverage or are we doing a 50 times coverage? 100 times means every nucleotide we read more than 100 times. 50 times is only read 50 times. So that makes a difference in terms of the validity of your data. Okay, so I'm going to highlight these few landmark publications again. You can see that prenatal exon It's quite a new field in prenatal because the two parallel Lancet papers were only published in 2019, and then subsequently there are more. But the key message is the same. Once we have a multiple congenital abnormalities, actually we have a much higher diagnostic group than the others. Okay, so the strength of the exon sequencing is that it's a very efficient method of analyzing a patient's DNA to discover the genetic cause of disease, because it analyzes tens of thousands of the exons or genes at the same time. And the exon is the well-known part of the genome. It's ideal to help us to understand the highly penetrant allelic variations leading to the disease. So we should have less worry about variants of uncertain significance or unknown significance. And it's less expensive than the genome sequencing and less data generated, so that the computational power, the things you need in your lab will be less. Most of our colleagues, no matter you're a clinician or a laboratory scientist, you don't understand when you have a lot of sequencing data, you need a supercomputer. You also need a very good hard disk to back up all your data. Without that, actually, you cannot do the work, right? So this is another important consideration. And I am not going to bore with you with all the data that Professor Mark Kilby has shown with you and others. The key point here is that most of the meta-analysis of review literature is the same, is that, okay, exon sequencing in fetuses with multiple abnormalities, like this one, you can see that it increased the diagnostic yield. For those cases already have CMA and calteching negative, right? But what's the level of difference? The main difference depends on what is the organ involved. We know that, for example, for us, we are more interested on the central nervous system, so you can see that actually they have a very good diagnostic. And if it's brain plus other multiple organ, actually the diagnostic is good as well. Okay, so this is the key message. And does it sound? Yes, it is, because at least if you refer to the International Society of Prenatal Diagnosis and update position statement, it has already stated that the current existing data supports that prenatal exon sequencing is beneficial for the following indication, okay? Following indication of, for all, okay? A pregnancy have a major single anatomy or multiple organ system anatomy. So central nervous system is an example. Or a person have a maternal or paternal history of a prior undiagnosed fetus or a child affected with a major single or multiple organ abnormality. So that, central nervous system and, neurological conditions is an example. But it also states that currently there's no evidence to support that routine testing, including up on parental request on fetal tissue obtained from an invasive prenatal procedure. Why is that? It's because I echo what all other speakers have been showing you. We need to have a phenotype so that we can interpret the genotype result. If the woman just have a high risk of advanced maternal age, or your fetal morphology scan is normal, and then they do a prenatal exon, how are you going to interpret your data? There's so much uncertainty. There's so much is unknown. So that's very difficult. That creates a dilemma. That's why prenatal exon sequencing at the moment is more guided and recommended for pregnancy with either a single major or multiple organ abnormalities. So where's the data? All the data, no matter O or U is the same. First, for sure, CMA and exon sequencing, they give an enhanced diagnostic yield. And the diagnostic yield is different, depends on what's the involvement of